Assalamu alaikum, everyone. I hope you're all having an amazing day. My name is Mohamad Behairy. I'm a second year medical student, and inshallah, today we will be talking about the lecture of testosterone, the second physiology lecture about the male reproductive system that you guys took. وكل عام وانتم بخير وصحة وسلامة. I hope studying in Ramadan will be smooth and light for you. And without any further delays, let's get started. Now, let's start by orienting ourselves a little bit in something you guys already know, but it will set the framework for this lecture. Let's figure out how testosterone is produced in the first place and what causes it to be secreted. First of all, let's agree that the command center of the body is the brain. The brain is the command center which causes everything to happen. For this brain, due to certain factors and things that will simulate it, will cause the hypothalamus to produce something called gonadotropin releasing hormones. These are the hormones that will then go to the pituitary gland and make it produce FSH and LH. Now, you guys know all of this. We're just going through it again, and I want you to understand it very well. Now, after we have this FSH and LH, these two will go to the testes, since we're talking about men and testosterone, and the testes, through the Leydig cells of the testes, will produce testosterone. So I hope this process is clear to you guys. But the thing is, this pathway is not the same always. Sometimes it's upregulated, sometimes it's downregulated. So we need to understand what factors will cause more of testosterone to be produced or less of it to be produced. Let's start by the factors that will affect the brain. First of all, we have leptin. And you guys took leptin in GIT. It is a hormone that is secreted when a person is full. يعني خلاص أكلوا شبعانين تم تعبئة الكرش بالنجاح يعني بالأخير. They're full of leptin. Well, this leptin will cause the brain to start this cascade of GnRH, FSH, and LH, which will eventually lead to an increase in testosterone. And I want you to remember leptin in specific because it will be important in a bit. Now, if there is something that will activate the brain, there has to be something that will, let's say, inhibit it. We have three important things that I want you to remember: interleukin 1, prolactin, and dopamine. Now, let's make sense of the three of them. Interleukin 1, you will take it in depth in POD, but essentially it's something that is released when there is inflammation in the body, an injury, whatever that might cause inflammation. And at times of inflammation, your body will not produce a lot of testosterone. That's why interleukin 1 is a factor that will negatively impact this pathway. Another thing is prolactin. Now, what is prolactin? It's a hormone that causes the production of milk in women, to be specific. Now, it's not the main cause, but prolactin is one of the reasons why a woman that is pregnant does not get any periods or menstruations. It's because prolactin is high. And when it's high, it's inhibiting the brain and preventing the secretion of FSH and LH. So that's a way you can remember in the prolactin inhibits this whole pathway. Last but not least, we have dopamine. Dopamine also causes a decrease in testosterone and in this whole pathway, to be specific. طيب, what are the things that will inhibit the hypothalamus? We have one important thing, testosterone. Why? A simple mechanism called negative feedback. So after the testosterone is produced by the testes, when this testosterone is in high amounts, it will go all the way to the hypothalamus and tell it, خلاص, we don't need any more GnRH, there is enough of me, the testosterone. Moving on to the pituitary, we also have negative feedback by testosterone, but more importantly, we have this hormone that is called inhibin. Now, inhibin, from its name, it inhibits. It inhibits the pituitary gland, specifically FSH. Essentially, inhibin, subhanAllah, it was made to regulate FSH. When FSH levels are very high, inhibin levels will increase to decrease this FSH. When FSH levels go back to their normal, this inhibin will also go down because خلاص, we don't want to inhibit the production of FSH anymore. So you guys have to remember inhibin. It's very important. They ask about it a lot. Now, if we have inhibin, something that inhibits, we will also have activin, something that will activate. Well, activin essentially goes to the pituitary, which tells it, give us more FSH and LH. So you can think of activin and inhibin as two things that counter each other always. Now, moving on to the testis, nothing inhibits the testis specifically. The testosterone that is produced by the testis will cause negative feedback in the steps before it. Now, for those of you who prefer text, the brain, wait a second. the brain centers stimulate the hypothalamus to release GnRH in a pulsatile fashion. Now, what does pulsatile mean? It means in this GnRH is not produced all at once. لا, let's say one hormone or one GnRH will be produced every 3 hours. It's in a pulsatile fashion, like how the heart beats مثلا blood at pulses, not all the blood in your body at once. The same thing happens in the hypothalamus with the GnRH. Now, after that happens, the pituitary will release gonadotropins, LH and FSH, and those will go to the testis and make it secrete the androgens, which is the testosterone. Now, as we said, leptin and activin will increase the release of testosterone, while inhibin, interleukin 1, prolactin, and dopamine will all decrease the release of testosterone. Now, an important point regarding inhibin. We have a specific type of inhibin, which is called inhibin B. Well, this is the one I want you guys to remember. This is the one that's specifically made for FSH. And when FSH increases, this inhibin B will make sure to regulate it, to bring it a bit down. Now, let's move on to puberty. Puberty, a phenomenon that happens to everyone. We need to understand the role of the hormones in puberty. Now, this is a graph in your slides which shows you basically the lifetime in years of a person or the levels of FSH and LH in every part of their lives. Let's start when the time when this person is not even born yet, when the mother is still pregnant with this person. During that time, FSH and LH will be relatively high. Now, the reason behind them being high is because when you're still not born yet, this is exactly when you're becoming who you are. This is when you're developing your primary sexual characteristics. If you're going to be a man, if you're going to be a woman, that is why during those trimesters, when you're still not born, when you're still a fetus, it's important that we have adequate levels of FSH and LH as they will basically dictate what your gender will end up being. Now, up until 6 months, we will see this increased levels of FSH and LH to make sure you develop properly and in alignment with your chromosomes. But after that, we will see a period of literally almost none of LH and FSH, which will extend up until puberty. Yani from 6 months until puberty تقريبا, no LH, no FSH. Well, this is logical. Yani we don't see a child who's 5 years old who مثلا develops characteristics seen in a person that went through puberty. فطبيعي إنه in this time we don't have much of LH and FSH. Now, let's talk about puberty in specific. Puberty is sleep-induced. It happens overnight. طيب, you might be asking, طب what is this thing in my body that tells it in tonight will be the night you go through puberty? It's a neurotransmitter. It's called kisspeptin. Well, this neurotransmitter will induce puberty, this overnight increase in FSH and LH. As you guys can see, LH, FSH, throughout puberty, حتى after, all throughout the reproductive years, they are high in increased amounts, especially LH. يعني LH fluctuates or increases more than FSH. ليش؟ لأنه LH is the hormone that is responsible to produce the sex hormones, testosterone or estrogen or هذولي. Doesn't mean that FSH is not important, but LH is the one that will increase the most. Or in a man, all throughout his reproductive years, يعني up until age 60, 70, FSH or LH will be high. While in women, the moment they hit menopause, which is essentially خلاص, they don't menstruate anymore, they will see an insane increase in FSH and LH. You will take this in depth in the female reproductive system physiology, but I don't want to leave this idea ambiguous to you. So all I'm going to say is when a woman stops menstruating, she will see a drop in estrogen. If she doesn't have enough estrogen, what is going to negatively feedback in FSH with LH? Nothing. It's going to spike. So just know this as general information from now. But I want you to know from this is that GnRH neurons are active during gestation. But why? To establish the primary sexual characteristics. وبعدين they're going to enter a long period of low activity. خلاص ما في LH, ما في FSH, ما في GnRH until puberty, which is sleep induced, happens overnight. It happens due to the neurotransmitter kisspeptin. Remember this. Well, as we said, LH has higher fluctuation in plasma than FSH. FSH levels are more stable, essentially. طيب. Now moving on to this slide, which was also in your PowerPoint that you've been taught by Dr. Abdul Jabbar. Now, you're never going to be asked anything by this. I put it for completion's sake, but essentially, the Tanner pubertal stage, it's like a table that shows you different stages which are used to identify this kid, مثلا, is he at stage 2 or stage 3 of puberty? Something like that, يعني. It's not very important for you to know. It's just interesting. مثلا, the height spurt should occur between this age and that age for women and men. But you will not be asked about this. طيب. So let's go to the first checkpoint. Does anyone have any questions so far? Okay, assuming that's a no, we're going to move on to this question. And now, for those of you in the live Zoom session, please answer in the chat. Those of you watching the recording, feel free to pause and answer, and then we're going to solve it together. So the question reads, a mother educated herself since she is concerned about the sexual development of her son. She asks the physician, an increase in which of the following is the primary event that initiates his pubertal development? This question is essentially asking, in which of the following causes puberty? So let's see the answer in the chat. D. لا, it's not D. شوف, the D is not wrong. يعني صح, أكيد the size of the testes will also indicate in that this person is going through puberty. But the question asks, what is the primary event? يعني what is the first thing that happens? We talked about it 2 slides ago. أول شيء يصير with the hormones. When this thing happens, puberty will start. Exactly, it's C. GnRH pulses. So we start with the GnRH pulses. بعدين increase LH-FSH. Increase testosterone, increase size of testes. You're not wrong, but this is why you guys have to focus on reading a question. The question here is not asking for the correct answer. It's asking for the primary, the first thing. You could have more than one right answer, but only one fits what the question wants. طيب, let's move on to another question. An 18-year-old male undergoes examination of the testes, revealing a single testis in his scrotum. Labs reveal elevated serum FSH and LH is normal. For the FSH is very high, while LH is normal. For which of the following substances is likely to be impaired in this patient? But essentially, this question is telling you what is the thing that normally keeps FSH at normal levels, ولأنه it's impaired in this case, the FSH is very high. طيب, for the answer to this will be A, inhibin. As we said, we have inhibin or activin. Inhibin, from its name, inhibits. It inhibits the FSH increase when the levels get too high. In this patient, he has so much FSH, which is not going down. It's because we have a problem with inhibin. طيب. Now let's talk about the fate of testosterone. After this testosterone is produced, what happens to it? We have a question. You also told us that we need testes to increase first so that testosterone increases and then puberty. Okay, so the question is essentially we need to increase the testes to increase testosterone. But before all of that, أصلاً, you need the GnRH pulses. It's impossible to secrete testosterone. It's impossible to increase the size of your testes if you're not going to have GnRH pulses. Let's go back to the first slide. هنا. Everything starts with the brain. Everything starts with GnRH. التستيز sizes والtestosterone هذه كلها آخر شيء. All of these things will never happen if we don't have GnRH pulses. So that's why the primary event in puberty is GnRH pulses. تمام? I hope that is clear. طيب, let's go back to fate of testosterone. Makes sense. Allah يعافيك. Okay. طيب, so we have this testosterone. طبعا it can be excreted. إنه خلاص, nothing happens with it, just gets excreted. Or it can transform into another form of itself, a stronger form of itself. We call this strong form dihydrotestosterone. Dihydrotestosterone is testosterone, but a lot stronger. It has its own functions, things that testosterone cannot do on its own. Now, I hate that this will look like biochemistry, but you need to remember the enzyme that transforms testosterone into dihydrotestosterone, and that would be 5-alpha reductase. So 5-alpha reductase is the enzyme that will bring this testosterone and turn it into its stronger self, which is dihydrotestosterone. Now, believe it or not, testosterone can also turn into estrogen. but not directly. It will turn into something that is 95% like estrogen. It has the same functions, but with a different name. We call it estradiol. Now, estradiol you will take later, inshallah, how it can become estrogen. But for now, estradiol, just remember, it's literally estrogen, which has the same effects of estrogen. Well, this reaction happens by the enzyme aromatase. So we have 5-alpha reductase making testosterone into dihydrotestosterone. We have aromatase making testosterone into estradiol. Tamam? Now, for those of you who like text, testosterone is converted to dihydrotestosterone, the stronger form, through 5-alpha reductase, or it can also be converted to estradiol through the enzyme aromatase. Now, guys, do you remember in the first slide when I told you in leptin, the hormone that's released in adipocytes when a person is full, can increase LH or FSH or testosterone? Now, I want you to keep this in mind and read this third point. More adipocytes equals more estradiol. لأنه estradiol is produced by adipocytes. But I want you guys to connect these two dots or arrive to a conclusion, which is that, let's say a man is fat. He has a lot of leptin. He's obese, or he secretes a lot of leptin. He has a lot of adipocytes. What will this mean? It means إنه he will secrete a lot of testosterone. لأنه this leptin will stimulate the brain, صح? But the thing is, this testosterone, because of the increased amount of adipocytes, this testosterone will be turned into estrogen, an estradiol. So that's why أصلا a morbidly obese man doesn't really look like someone with a lot of testosterone. مع إنه logically they should have more testosterone. Or they do, but all of this testosterone is turning into estradiol thanks to the abundant amounts of adipocytes. Well, that's why in morbidly obese men, we can see in أصلا they start developing female breasts, gynecomastia, we call this phenomenon. So keep this in mind for now. Now, something, just remember it as this صراحة, in the seminiferous tubule, which is a part of the testis, the testosterone is bound to something that we call androgen binding protein. This protein is found in the seminiferous tubule. Now, something important to know, testosterone can only produce effects, or it is only active when it's free, when it's not bound to anything. For when it's bound to something, it's not active, it's not producing effects. Now, something else that testosterone can bind to is sex hormone binding globulin. وهذا حكايته حكاية. Let's get to it. Now, let's say we have a person called Ali, a guy named Ali. Ali has 4 molecules of testosterone right now. He has 3 molecules of estrogen. طبيعي, a normal balance you will find in any man. Now, these hormones come into contact with sex hormone binding globulin. What does this do? It's called a binding globulin. فأكيد it will bind those hormones. Keep in mind, throughout this pathway, I want you to keep one thing in mind. A hormone is only active, most specifically testosterone and estrogen, only when they're free. For when they're bound, they're not active. تمام? For this sex hormone binding globulin will bind to these hormones. But I want you guys to focus on the arrows. These arrows are not random. This sex hormone binding globulin is sexist. He likes to bind to testosterone and androgens more than estrogen for some reason. But in the aftermath, we're going to have this sex hormone binding globulin. We're going to see that it's holding a lot of testosterone with only little bits of estrogen. طيب, okay, what does this tell us? What is the significance of all of this? The significance is that in the aftermath, when we want to measure the free hormones, the ones that can actually help us or give us the desired effects, we're going to find, and even though Ali is a man, he has more estrogen than testosterone that can produce effects. This is bad, لأنه Ali will start developing female characteristics done by estrogen, and the testosterone is too little, that a lot of things will be impaired. طبعا, in a normal person, the sex hormone binding globulin is at normal levels, but there are certain diseases, خلينا نقول, that can either increase the amounts of this sex hormone binding globulin or decrease it. Let's take a look at them through this table. إيش يعني increased sex hormone binding globulin؟ يعني hyper sex hormone binding globulin. ولأنه it's hyper, it will be caused by hyperthyroidism. This is how you can remember what causes it. تمام؟ Or an increased sex hormone binding globulin, like we saw in the previous example with Ali, we're going to have a lot of this testosterone being bound. So what will this cause? It will cause increased estrogen effects. Then we will have more estrogen that is free, not bound to anything. This will lead to female effects such as gynecomastia, developing of breasts in men. So in the other way around, what if we have hypo-sex hormone binding globulin, a decrease in this globulin? This أول شيء it will be caused by hypothyroidism, hypo مع hypo. طيب, if we have يعني less than normal of this globulin, what will happen? The androgens, nothing will bind to them. They're going to be free, كلهم. What will this lead to? Increased androgen effects this time. All of the testosterone is able to exert their effects, mashallah. What will this cause, especially in women? Hirsutism, which is essentially male patterns of hair growth in women. طبعا, one of you might be asking right now, طب this decreased hormone binding globulin, couldn't it happen in men? And why is the effects only related to women? صح, it can happen in men. But what is the effect? Increased androgen effects. It's not that interesting to talk about it in a whole slide. What's interesting is seeing the effects on the other gender. Yani when we have too much estrogen, what will be the effect on the man? When we have too much testosterone, what will be the effect on the woman? But أكيد, these two cases can happen in both men and women. Now, moving on. The functions of androgens, testosterone in other words, I'm sure you guys are familiar with it, but I want to highlight a few points that are encircled. First of all, I told you back then when we talked about dihydrotestosterone, and there are things that happen through dihydrotestosterone that cannot happen by testosterone. What are these things? Let's take a look at them. The growth and development of the penis, scrotum, urethra, and prostate are all happening through dihydrotestosterone. So if, let's say, a patient presents with deficiency in dihydrotestosterone, it's safe to assume that they will have some sort of deficiency in their penile development and growth. Tamam? Now, the epididymis with a vas deferens, the seminal vesicles, these internal reproductive male organs, are all developed through testosterone, not dihydrotestosterone. طبعا, you don't have to remember every single function here meanly, so I just want you to know the ones in circles. They're the most important. إنه dihydrotestosterone for penis and scrotum, testosterone for epididymis, vas deferens, وهالأشياء. طيب, a very important thing is that sperm production can happen through dihydrotestosterone or testosterone, both of them. Sperm production wouldn't be impaired if we have a little bit less of dihydrotestosterone, for example. Last but not least, the bones. شوف, testosterone always initiates or promotes growth, whether it's growth of muscles or bones. In a person with a lot of testosterone, they're going to have a lot of muscle growth, their bones will grow a lot. But in this case, why do men eventually stop growing, especially their bones? It's because of estrogen. What does estrogen do? Estrogen closes the epiphyseal plates in the bones. فخلاص, the bone cannot elongate or enlarge anymore. Let's say a patient presents, a man with estrogen deficiency, ما عنده estrogen. What will this cause? أول شيء, what would the patient look like? He would look very tall, and not in a good way, in a very bad way. لأنه these bones أصلا are weak. يعني these bones, it's not like they're tall in a good way, they're weak. So that's how a man with estrogen deficiency would present. طيب, now it's important to know when androgens, testosterone, are steroids. Well, how do steroids work? This is an important thing. We want to know how do testosterones work. Now, I'm sure you took this somewhere, but I'm just going to touch upon it very briefly, very fast. We have the nucleus or we have the cytoplasm. Testosterone جاي من برا, he's knocking the door, he wants to go in. And so he does. He goes into the cytoplasm. In the cytoplasm, he's going to find someone waiting for him. That someone is the androgen receptor. It's going to bind to this testosterone with this complex of testosterone and androgen receptor together will go inside the nucleus. In the nucleus, the testosterone will freely initiate transcription, which will be caused or which will be done to develop the vas deferens, to initiate muscle growth, وهالأشياء كلها. But this is how this all happens. But for those of you who prefer text, androgens are steroids, so they exert their effects by initiating transcription after reaching the nucleus of the cell. So the binding of testosterone to the androgen receptor, it will allow the nuclear translocation of the androgen receptor complex. But when they combine this testosterone with androgen receptor, Together, they will be able to go to the nucleus. What is the effect? Increase in transcription of the testosterone responsive genes. We will have the desired effects. طيب, do you guys remember 5-alpha reductase وهو إنه this enzyme turns testosterone into dihydrotestosterone, the stronger form of testosterone? Well, in actuality, this enzyme has two types, type 1 or type 2. Nothing too serious. I just want you to know إنه type 1 is responsible for the sebaceous glands or the acne that's seen in puberty. While type 2, well, there is a reason why it's highlighted in yellow, it's, in my opinion, the more important one, and it's found in pretty much everywhere else. It's responsible for male muscle growth, hair growth, reproductive organs growth and maturation. Everything aside from acne or sebaceous glands is done by type 2, 5-alpha reductase. طيب, for 5-alpha reductase, we know when the testosterone is converted to DHT by 5-alpha reductase. Well, there are two types, type 1 and type 2. Type 1 is found in sebaceous glands and is responsible for the acne that is seen during puberty, while type 2 is found practically everywhere, responsible for penile growth, body hair growth, etc. Now, 5-alpha reductase inhibitors can be used. ليش؟ لأنه they will treat prostatic cancer, for example. Let's go back. I want to explain this in the best possible way. هنا صح قلنا إنه DHT can cause أو it's responsible for the proliferation and growth of the prostate. طيب, let's say we have a cancer of the prostate. The prostate is growing too much. What hormone can we inhibit to make sure that the prostate doesn't grow too much? We can control the cancer. We would inhibit DHT. طيب, how can we inhibit DHT? How can we decrease the levels of DHT? By inhibiting the enzyme that makes it, which is 5-alpha reductase. But that's the point I wanted to make clear. طيب, another checkpoint. Does anyone have any questions? طيب, if not, we're going to move on to a question that I have for you guys. Developmental sex disorders may occur in a male baby owing to 5-alpha reductase deficiency. Which of the following abnormalities is most likely associated with the baby? Yani, what is this telling you? A baby does not have 5-alpha reductase. If he does not have 5-alpha reductase, what does this mean? He won't have dihydrotestosterone. طيب, if someone doesn't have 5-hydrotestosterone, what will the effect that we will see? The answer would be D, ambiguous genitalia. Let's go through the other options first. Virilization. مال أبوها دخل. Virilization means إنه we have a woman, well, this woman has male sexual characteristics and normal male characteristics. ما لها دخل بالعكس. Dihydrotestosterone would promote this. طيب, hypertrophy of testes. بالعكس, why would a decrease in 5-alpha reductase, therefore decrease in dihydrotestosterone cause a hypertrophy of the testes? بالعكس, if we don't have enough dihydrotestosterone, it would be safe to assume that the opposite might occur. Regression of the paramesonephric duct, this is something embryological أصلا, يعني it's not related to this enzyme. Ambiguous genitalia, it is the correct answer. And as we said, dihydrotestosterone. I'm going back to that same picture. I'm going to go back to it. It's responsible for the development of the penis, the scrotum of the prostate, which are the external genitalia. If we have an issue with the development of these things, we're going to have ambiguous genitalia. لا البينس طالع زي الناس ولا السكروتم ولا anything else. I hope that is clear. Now, let's move on to the most fun part of the lecture, in my opinion, which are the clinical cases. تمام? طيب, let's have a little story. This is our friend Jack. Jack is a person that likes to go to the gym, but he's getting impatient. He wants to build muscle as soon as possible. He finds this thing that is called steroid injection. Basically, testosterone that he can inject into himself. Well, this testosterone على طول will go to the muscle and make him stronger. But after injecting this testosterone, he noticed he started developing a female breast, gynecomastia in other words. Oh, his wife noticed Jack is so angry. Yani he's always aggressive and angry for some reason. Jack, once upon a time while taking a shower, noticed his testes are really, really small, which is counterintuitive for a person that goes to the gym and is taking all of these steroids. طيب, so what is the issue in this equation? It's safe to assume that these steroid injections are the problem. طيب, how does these steroid injections يعني cause these negative effects? أول شيء, we have this testosterone that is coming from the injection. This testosterone will go to the muscle, will make it bigger. طيب, what will it also do? It will inhibit the release of GnRH. Why? Negative feedback. مو احنا قلنا in the first slide ان testosterone can negatively feedback or negatively regulate whatever is above it. طيب, this is the same here. مو يعني testosterone is from outside يعني خلاص it's not going to regulate anything. لا, it will. What will this cause? A decrease in LH and FSH. What will this cause? Azoospermia, which essentially means ما عندنا sperm. طب why exactly? لأنه when testosterone causes negative feedback, it's inhibiting both LH and FSH. When it inhibits FSH, it will also inhibit sperm production. طب now one of you would be asking, طب why is this only seen with exogenous testosterone? طب والtestosterone اللي inside the body أصلا, why doesn't it cause the same thing? لأنه كلهم they do negative feedback. The answer is in the second point. The testosterone from the outside will cause a decrease in the testosterone that is in the testicles. And when you inject testosterone, it will not go to your testes, it will go to the muscles على طول. When the GnRH is less or the LH or FSH is less, the testosterone that would usually be produced in the testicles هيكون less. لأنه the body is saying خلاص في testosterone ثاني. Why do we need testosterone in the testes? So that's why it will cause the testes to become smaller, hence less sperm count. But in the normal case, when testosterone is produced in the testes, not in the muscles or anywhere else, it won't cause a decrease in testicular size. When the testosterone is being produced in its normal place, بالتestes, unlike in this case. For abuse of androgenic steroids to build muscle has several side effects, including aggression, decrease in the size of the testes, and azoospermia. كمان gynecomastia طبعا. طيب, last point, in what if this happens in women? What if for some reason يعني صراحة a woman injects steroids? For some reason anyone injects these stuff صراحة. But in women, we're going to see virilization. Virilization. What is virilization? We talked about it a few slides ago. It's essentially presence of male features in women. فحيصير عندها, for example, hirsutism. Presence of hair in parts of the body where there shouldn't be hair, يعني in the female. Yeah, in both genders, this will cause detrimental effects. Right. Let's move on to aromatase deficiency. Now, what is aromatase? The enzyme. We said, it's the enzyme that turns testosterone into estradiol, which is essentially estrogen. If we don't have enough of this enzyme, we're not going to be able to produce estrogen in men. طيب, what is the most important function of estrogen? Not in general, the one I talked about a few slides ago. And it closes the epiphyseal plates of the bones. It restricts growth of the bone. إنه خلاص, a person will not be able to have longer bones anymore. In a patient or a person without this estrogen, he's going to be immensely tall. And the epiphyseal plates just don't close. He keeps getting taller and taller and taller. This will lead to osteoporosis. What is osteoporosis? Decreased bone density. Now, for you guys to remember, it causes osteoporosis, I'm going to explain it with an equation we used to take back in school. Density equal mass over volume. Osteoporosis means decrease in bone density. طيب, how do we decrease the density? By either decreasing the mass or increasing the volume, then they're inversely proportional. When the bone is growing and growing and growing, when epiphyseal plates are not closing, when the bone is still growing and growing and growing, we're going to have an increase in the volume. But this increase in the volume is not being met with the same increase in mass. يعني if something is big, it doesn't mean that it's heavy. Well, that's why at the end of the day, in the aftermath, the density of the bone will decrease, which will lead to osteoporosis. طيب, now let's talk about things that are not caused by enzymes, but are caused by the organs themselves, مثلا the testes or the hypothalamus أو إلى ذلك. Let's start with the normal case. We have the hypothalamus giving GnRH, the pituitary giving LH or FSH, with the testes giving the testosterone. This is the normal case. طيب, what happens in a primary failure? Primary, يعني the issue is with the last organ, اللي هو التestes. طيب, هنا what is the problem? The problem is إنه the hypothalamus والpituitary شغالين, they're doing their job. But even when they're doing their job, the testes, they're not responding. All of this LH or FSH is being produced. Even with that, the testes are not producing the testosterone that it should be producing. For here, the pituitary gland will be thinking to itself, why is this happening? What should I do for the testes to produce testosterone? It will think it has to produce more LH or FSH. وhence why we have an increased amounts of LH or FSH مرة كثير just to try to make the testes give testosterone. We call this hypergonadotropic. ليش؟ لأنه these are the gonadotropes. If this is gonadotropin releasing hormone, it will release the gonadotropes. The gonadotropes are supposed to release the gonads, which is the testosterone. We call this hypergonadotropic, which means we have too much of LH and FSH. But what about in secondary failure? Now, secondary failure is not a problem with the testes, it's a problem with something higher above, most notably the pituitary or the hypothalamus. Essentially, the aftermath is we don't have enough LH or FSH. But the testes is not being stimulated enough so it can produce the testosterone. ما في LH FSH, فwhy would the testes produce testosterone? We call this hypogonadotropic, لأنه we have too little of FSH and LH. Now, let's differentiate between two important things. Hypergonadism or hypogonadism. Now, this is different from what we talked about in the previous slide. From the previous slide, we were talking about hypergonadotropic and hypogonadotropic, which is LH or FSH. Now we're talking about gonadism, which is the testosterone itself, not the LH, FSH, لا, التستوستيرون نفسه. For hypergonadism means we have too much androgens. What would this cause? Something like early puberty. A person would be short due to early puberty, لأن the epiphyseal plates would close faster. This can happen due to two main mechanisms. تمام? Let's go back here. Let's use a pointer. Either إنه there is too much LH و FSH و GnRH, يعني the problem is from the hypothalamus مثلا, or إنه the LH و FSH are normal بس المشكلة are from the testes مثلا, or from the adrenal glands. It's producing too much androgens. For the problem always can either be from the hypothalamus or pituitary or from the organs that secrete the testosterone. In this case, it can be due to too much GnRH or normal GnRH, but there is too much androgen production. Now, guys, just to orient yourselves, red matches with red, blue matches with blue. For too much GnRH can be due to tumors in the central nervous system. يعني a tumor of the hypothalamus مثلا. It will release too much GnRH. Or in the case of normal GnRH, but too many androgens being produced, this can be seen in adrenal hyperplasia. When the adrenal gland يضرب ويصير cancerous, which starts secreting a lot of androgens, this would cause hypergonadism. طبعا something you guys have to remember, they ask about it in exams, it might come, إنه adrenal hyperplasia in women, it can cause scrotum growth. And a girl that has congenital adrenal hyperplasia, ممكن فجأة she has a scrotum, she develops a scrotum. تمام? Remember this. Now moving on to hypogonadism, too little of these gonads, too little of this testosterone. This is seen in Kalman syndrome and Klinefelter syndrome. Two syndromes that sound the same and are similar in their own ways, but we're going to talk about them in depth. Let's wait on that. This can be due to too little FSH و LH, which is causing the hypogonadism, أو إنه the FSH و LH are normal, but the testes are not responding. When it's too little GnRH, معناتها المشكلة بالhypothalamus, this is most likely genetic. Okay? It can't be a cancer, لأنه the cancer will cause an increased release. عرفتوا؟ بس هنا it's most likely a mutation in something. أو we can have normal GnRH, طبيعي للhypothalamus, but the testes are not producing the testosterone. So in this case, it would be a testicular dysfunction. Let's move on to Kalman syndrome. Kalman syndrome is a hypogonadotropic hypogonadism. إيش يعني؟ hypogonadotropic يعني LH و FSH قليل. ولأنه ال LH وال FSH are little وقلال, we're going to have hypogonadism. يعني زي هنا what's written, low LH and FSH leads to low androgens. تمام? Which is equivalent to this. This exactly. This is Kalman syndrome in a nutshell. The secondary failure. طيب. For what does this cause? It will cause anosmia, lack of smell. This is something you have to remember. Kalman syndrome, what does it involve? It involves low FSH to LH, which is due to a problem in the hypothalamus. If we have a problem in the hypothalamus, if we don't have GnRH in the hypothalamus, this will lead to a loss of smell. But the patient wouldn't be able to smell. Anosmia means lack of smell. Remember this. It's very characteristic of Kalman syndrome. Males are more frequently affected than females, with the males also go through this phenomena called cryptorchidism. Cryptorchidism is essentially the testes are not descended. Yeah, into you took an embryology that the testes slowly go down till they reach the scrotum. هنا لا, the testes they don't descend. Last but not least, in Wolffian ducts, you guys took this in the first physiology, male reproductive physiology lecture. In Wolffian ducts form because of androgens. طب wouldn't logically in a syndrome that causes too little androgens ما حيصير عندنا Wolffian ducts أصلا? Luckily for these patients, the HCG will produce some androgens that will cause the Wolffian duct to be there normally. But the problem is penis development will be severely deficient. Yeah, the Wolffian ducts, okay, they will form normally. But other important things that are done by testosterone, keep in mind, if we don't have testosterone, then we also don't have dihydrotestosterone. So this will lead to impaired penis development. طيب, now let's move on to Klinefelter syndrome, known as the XXY syndrome. It's a normal guy who is XY, but عنده an extra X chromosome. With this one X chromosome, so one مصايب. First of all, this is a hypergonadotropic hypogonadism. ايش يعني؟ يعني ال LH وال FSH it's too much, it's being secreted, the pituitary is trying its best. بس لسه the testosterone is not enough. The testis is not responding, it's not giving us what we want. If we go back, it's this case, primary failure. إنه the pituitary it's doing its best, it's giving the LH وال FSH, بس the testes مو راضي يعطينا testosterone. This is what's happening in Klinefelter syndrome. For we have lots of FSH and LH, yet no androgens, meaning testicular failure. But this is due to meiotic non-disjunction, XXY, the person will have 47 chromosomes, which will lead to atrophy of the testes. The testes, they failed. They're just going to shrink, atrophy. ما منهم فايدة. Gynecomastia. This person, لأنه he's not producing testosterone, he's going to develop breasts وفيميل hair patterns. كمان infertility. يعني مساكين خلاص they're infertile. Klinefelter syndrome is a very serious thing. Subhanallah, all of this happens due to an extra chromosome. Now, something you need to know إنه إحنا قلنا إنه FSH و LH are a lot. ليش؟ لأنه ما في testosterone, the pituitary is trying its best to increase the FSH with LH. But why exactly does this happen? طيب, let's start with this. Decreased testosterone will lead to increased LH. طبيعي. طيب, what about the FSH? Why does the FSH increase as well? احنا قلنا the testes will atrophy, صح؟ حيصير في testicular atrophy. When this happens, the seminiferous tubules of the testes حيخربوا. When this happens, we won't have any more inhibin B. لأنه inhibin B يعني it's made in the seminiferous tubules. طب احنا ايش قلنا the function of inhibin is in the beginning of the lecture? قلنا the function is to regulate the levels of FSH. For now we don't have this regulator, for the FSH will skyrocket. Now, let's differentiate between the two syndromes as serial and they can be confusing. Kalman is hypogonadotropic hypogonadism. المشكلة من الhypothalamus. ولأنه we have a problem with the hypothalamus, the person will lose his sense of smell. Klinefelter, the hypothalamus will pituitary are good, hypergonadotropic. They're giving a lot of LH to FSH, but the testes are not producing the testosterone. ليش? We have an extra X chromosome. In Kalman, the chromosomes are normal. طيب, what is the main thing seen in Kalman syndrome? إنه the penis will not develop well. While in Klinefelter حنشوف testicular atrophy, حيصغروا التستيس, gynecomastia, breast development, and infertility. Let's move on to another story. We have a little girl, تمام? This girl is having, mashallah, a very bright life so far, who finally puberty hits her. But her parents notice something weird when she starts, يعني when her reproductive organs are starting to grow. They notice in, يعني this shouldn't look the way it is. There's something wrong. they notice إن she doesn't even have a clitoris in the first place. وإن this clitoris is actually a mini penis. And they start being worried إن إيش السالفة? Our girl has been normal her whole life. She looks like a woman. She acts like a woman. Why is this happening all of a sudden? They go to the doctor. The doctor decides to do an ultrasound to make sure that everything inside is normal. But he realizes that she doesn't even have a uterus. So she doesn't even have a uterus in the first place. بدأ يشك in why is this happening? So he undergoes some genetic testing where he finds out that this girl is actually a guy, or the chromosome is actually an XY chromosome. طب how did this happen? كل هالشيء. It happened due to a syndrome called androgen insensitivity syndrome. What is this? It's a genetic disorder where the testosterone is there, but it can't exert its effects. لأنه the androgen receptors are not working. مو احنا قلنا من زمان انه the testosterone binds to the androgen receptor ومع بعض يروح النيوكليس. Yeah, this can't happen. التستوستيرون موجود in high amounts, but it can't produce its effects. For what will this lead to? Normal testes, but they will descend into the labia majora. ما حيكون في scrotum. The testes are not even visible يعني in the first place. But this person, this guy, won't even have the scrotum. Other than that, the Wolffian duct, which generates through the androgens and testosterone, it won't even be there. ما حيكون في Wolffian duct. بس طيب انت قلت ما في Wolffian duct. But this person also doesn't have a uterus inside her or him. For what happened exactly? More this person's chromosome is XY. What did you guys take in the first lecture? There's the SRY gene that's found in the Y chromosome. What does this cause? The anti-Mullerian hormone. This will be there. The anti-Mullerian hormone will be present, which will cause the Mullerian duct to regress. فلا حيكون عندنا uterus ولا حيكون عندنا seminal vesicles وهالأشياء. لا Wolffian duct ولا Mullerian duct. In conclusion, the patient does not have any internal genitalia. But on the outside, it will develop يعني على تقدروا تقولوا الفطرة لأنه you guys know every baby starts developing as if it's a female وبعدين when the SRY gene with anti-Mullerian hormone comes into play, that's when it becomes a male. But in this case, the external genitalia will look like a female external genitalia. The phenotype is a female. يعني what is the phenotype? How the person looks like. The phenotype, it's a female. Everything يعني in this person is female. But he's actually a guy, he's actually يعني a man. بس المشكلة إن all of the testosterone in his body is not producing any effects. So that's why they end up looking like this, like a woman يعني. طيب, final checkpoint. Moving on to a few practice questions. Now you guys remember me from the alternative carbohydrates past session. When I say wallah, a question is coming, it means it's coming. The syndromes we were talking about, خصوصيا Kalman, Klinefelter, androgen insensitivity, these three, wallah al-azim, you're gonna get at least one question about one of those three. So let's focus on the practice questions that we're going to solve right now. ويعطيكم العافية. The first question. A 25-year-old man is found to have small testes on physical examination. He has normal male pattern facial and pubic hair. Further laboratory testing reveals a decreased sperm count, but the testosterone levels are normal. For which of the following is the cause of these findings? Small testes, normal testosterone, or decreased sperm count. This is characteristic of C, exogenous androgen use. This is not Kalman syndrome. Testosterone is normal. This is not Klinefelter syndrome. Testosterone is normal. This is not 5-alpha reductase deficiency. This person's testosterone is normal. الموضوع ما له دخل بالتستوستيرون. It's exogenous androgen use. Moving on to the next question. A patient has not gotten her menses yet. You check to find out she doesn't have any internal female structures. She doesn't have internal female structures, and her vagina has a blunt end. You don't know, is this a clitoris? What is this exactly? For what is most likely to be diagnosed? The answer to this would be androgen insensitivity syndrome. You guys didn't take Turner's. Exogenous androgen use ما له دخل with not having internal female structures. يعني ايش if someone injected testosterone, the uterus will disappear مثلا. وإن Klinefelter syndrome, this isn't the case. لأنه in Klinefelter syndrome it affects males يعني In a guy, you wouldn't be surprised in that there isn't a uterus inside her or something. Or in a guy, you wouldn't see a vagina with a blunt end in Klinefelter syndrome. يعني. The answer is A, androgen insensitivity syndrome. Moving on to this question, a 35-year-old weightlifter who has been injecting testosterone to build lean muscle mass. قالوا لكم what this guy is doing. He's taking testosterone. He's evaluated for sterility and found to have extremely low sperm count. Which of the following is responsible for sterility or low sperm count or all of the bad things happening? It's going to be B. This testosterone that's coming from the outside will inhibit the release of GnRH فما حيصير عندنا LH و FSH ما حيصير عندنا sperm production infertility in the end. طيب, moving on to the last question. The external genitalia of a 6-year-old girl shows an enlarged clitoris and fused labia majora that have formed a scrotum-like structure. Which of the following diseases can mimic this situation? In other words, it's telling you which of the following can cause a girl to form a scrotum. We talked about this. The answer would be D. A ما خفتوها, C ما خفتوها, and in androgen insensitivity syndrome, our problem wouldn't be in they form the scrotum. لأنه in androgen insensitivity syndrome, you wouldn't even form a scrotum. لأنه the testosterone that is responsible for making the scrotum is not being able to work properly. فكيف حيكون عندنا scrotum if we have androgen sensitivity? تمام? Now, there was a slide or two about this in Dr. Abdul Jabbar's lecture. Now, he didn't add anything new. This is exactly what you guys took with Dr. Ahmed Yaqeen al-Din. But there's no reason for me really to talk about this again. You already know this from that lecture or from that past session. But a piece of advice, wallahi, once again, you're gonna be asked about the effects of a deficiency in one of these enzymes. 21 hydroxylase, 11 beta hydroxylase, or 17 alpha hydroxylase. Know them very well. بس احفظوا. Know إنه if this is deficient, we will have more of this and less of this. If that is deficient, حيصير this and that. Know this very well. وصراحة, you don't need to study this from Dr. Abdul Jabbar's lecture. It's I would say it's better for you to learn this from Dr. Yaqeen's lecture, the adrenal physiology. Oh yeah, I just wanted to highlight it or tell you guys to not sleep on it. Yani, it's very important. Other than that, thank you guys so much for your time. I hope that this past session benefited you one way or another. As always, feel free to contact me anytime. This is my phone number. And please scan the QR code to give us your honest feedback. There is always room for improvement. So inshallah, future past sessions will be much better than this one. Without further ado, thank you guys so much. وكل عام وانتم بخير وصحة وسلامة. Thank you guys.